Saudi Heart Association. It's a way to meet a pain expert and to discuss pain medicine. And I'll take this chance to talk to you about the Saudi Society of Pain Medicine until Dr. Fakhr joins us. She joined us again. The Saudi Society of Pain Medicine has been approved preliminary in 2008, and we get the final approval in 2010. Since that time, we try to spread the word about pain and pain management among medical staff, doctor, pharmacist, nurses, technician, all the medical specialty. And we try to educate the public as well. We're conducting annual conferences, many pain clubs and symposium in the kingdom and outside the kingdom. And this activity, it's only the beginning, and we promise that we're going to continue, inshallah, not because of Corona, but it will be a habit, inshallah. It's a good habit. And I like to remind you that your certificate, you will get it through the email. So don't ask about it, don't worry. We will register you with the Saudi Commission for Health Specialty, and you will get your certificate by email. And the whole webinar will be on YouTube, and it will be in both societies' webpage. I leave it for Dr. Fakhr if she wants to add anything. Dr. Fakhr.
Assalamu alaikum wa rahmatullah.
Assalam.
Welcome everybody. Welcome our colleagues, the Pain Society. It's a pleasure, of course, to work with you in collaboration, the Saudi Heart Association with the Pharmacy Group. I'm glad to have our expert in pain in Saudi Arabia. Of course, it's a pleasure, our great speakers and moderator. This is actually the first collaboration that will happen between the Saudi Heart and the pain management, but it will not be the last. We are here actually to discuss points that we usually find in the rounds. We always have a problem in our cardiac patients. What is the proper management for their pain, either acute or chronic, in a safe way, safe to the heart? Because again, this is what we are facing with different drugs and therapies and pathway of pain management. The Saudi Clinical Pharmacy Group is glad to start this webinar. We are here to discuss with our pain expert in order to make sure that they will discuss with us in a very professional basic knowledge about the proper use of, first of all, the pain management methods and the proper use of medications for the patients. The goal of this webinar, as Professor Kaki was telling us, is to touch about the pathways of pain. What is pain? What do we mean by that? Of course, if we have a pathway, how to tackle this pathway, how to make it minimize the pain for the patient. The Saudi Clinical Pharmacy Group is promising our valuable audience that this would be a series. We have lots of points to discuss it today, inshallah, with our expert. This webinar is sponsored by Pfizer. Thank you for this sponsorship, and it is through the Saudi Heart Association with collaboration of the Pain Society Management. And I'm glad to start with Dr. Adel Kamal. I will leave this for Dr. Al-Kaki to introduce him, but in the meanwhile, I would like to remind everybody that the questions would be given in the end of the session because we would really like first to learn a lot from our expertise, and we will have all your cases being answered in the end of this webinar. So thank you very much, Prof. Kaki, for this nice introduction, and I will leave you now to introduce your colleague, Dr. Adel, and to give the mic to Dr. Adel, inshallah. Thank you so much.
Thank you, Dr. Fakhr. Dr. Adel is a brother and a colleague, and we know each other for many years, and he is well known in Saudi Arabia and in the Middle East. He is an American diplomat with an American board in anesthesia and in pain medicine. He is the director of the perioperative service in King Faisal Specialist Hospital and Research Center in Jeddah, and he is one of the pioneer in the pain medicine field in Saudi Arabia. Dr. Adel.
Assalamu alaikum. Thank you very much, Prof. Abdullah, for the introduction. Thank you all for joining us this evening. I hope what we're going to present this evening will going to be useful and informative for all of you. The title of my presentation is Pain Management, a Glimpse. Of course, it's very difficult to cover pain management in 30 or 35 minutes, but I will try to give you just a brief idea about pain management. And we will start off with the definition of pain. The International Association for the Study of Pain defines pain as unpleasant, sensory, or emotional experience due to actual or potential tissue damage. But the majority of pain practitioners define pain as whatever the patients say it is, whenever the patients say it is. So the issue here, we cannot project our own feelings into the patient's feelings. What might not be painful to me could be painful to someone else. So we have to take that in consideration. Pain is one of the most common symptoms that the patient present with to seek medical advice. Yet it is the most poorly treated symptom that the patient gets. Pain management is a problem, is a global problem. It is not only unique to us in this part of the world, but it's a global problem. In fact, in 1987, Donovan studied a sample of about 2,000 patients in both medical and surgical floors, and he found that about 75% of those patients presented with pain. Yet they only received 25% of the amount of medications that they were supposed to receive. In 2005, the International Narcotic Control Board published this report. International Narcotic Control Board is a subdivision of the WHO, and they monitor narcotic use all over the world. And in 2005, they issued a report about the narcotic use in 2004. And they mentioned that in 6 countries in the world, they use 80% of the total amount of opioids used all over the world, while in the developing countries where 80% of the world population lives, they use only 6% of the total amount of opioid used in the world. That same year, they mentioned that the narcotic use in the country of Saudi Arabia was only 2% of the international average. So that means if everybody else uses 100 tons per year, we use only 2 per year. So pain management was a problem and still is a problem. This is a report of the same International Narcotic Control Board about narcotic use all over the world, and that was published in 2018, only 2 years ago. And the situation is that much different 15 years later. You can see North America and some parts of Europe and Australia where the colors are brown and orange, and that indicates narcotic use. I understand some people will say, well, okay, they have narcotic problems, but you can check the rest of the world and you can recognize that many countries in the world, including our country, the pain patients are underserved, and there are many factors leading to that. One of the main problems is lack of formal pain management training. I am an anesthetist by training, and as part of our training, we get exposed to different opioids during our training, and we learn how to use those opioids, and we learn how to treat their side effects. Other specialties, they don't have that as part of the training or as a curriculum, and I'll give you an example. I used to be a urology resident before switching to anesthesia. And I can tell you, I did not know anything but pethidine, and my senior resident did not know anything but pethidine. So we only use pethidine. So we, as any other physician, we will use medication that we know. And if we don't know them, we're not gonna use them. Another problem, currently, when we talk about pain management training, even our country, we are currently the Saudi Board of Pain Management was just approved about 4 to 5 years ago. And so far, we only have about 19 candidates. So the total number of pain physicians all over Saudi Arabia is not more than 35. So that gives you an idea about the magnitude of the problem in this country, because our population is about 30 million. And if we talk about 35 or even 40 pain physicians, we're talking about 1 per million. So that gives you an idea about the magnitude of the problem. Another problem is errors in pain assessment by physicians and nurses alike. Unfortunately, we tend to judge if the patient is in pain by simply looking at the patient, not talking to the patient sometimes. And I do round in the acute pain service sometimes. And one time I was going to a patient room, and the nurse told me, don't worry, doctor, he's comfortable, he's not in pain, he's actually sleeping. That could be true, that the patient is comfortable, that's why he's sleeping, but it's also possible that the poor patient has been suffering from pain for so long that he simply fell asleep. So errors in pain assessment, that's a problem. Misinterpretations of the orders, especially written orders. Sometimes we get improperly written orders. Like one example, one of the orders I saw is pethidine 25 milligram TID. And I asked the resident, what's wrong with this order? And he said, 25 is wrong. And I said, the whole order is wrong. Pethidine is wrong, 25 is wrong, there is no route, there is no frequency, inadequate frequency. And so any prescription, when you write a prescription, you have to have the drug, the dose, the frequency, the duration. So, and the route, of course, drug, route, frequency, duration. Those are the elements that has to be present in every prescription. Also, one of the problems in pain management is we tend to think that traditional emphasis on PRN. We think PRN is better and safer and for the patient, and we can provide adequate pain treatment for the patient that way. And unfortunately, that is not true. And this is just a diagram or a graph that shows you the difference between using regular dosing, and here we are comparing PCA to IM PRN dosing. And if you are planning to provide adequate pain control, you are definitely going to use less medication when you give it regularly compared to PRN dosing. And you will definitely avoid these fluctuations in the plasma level, peaks and valleys in the blood level of the drug. The PRN here is in red in the diagram, and the regular is in blue. So that gives you a comparison of how stable you get in a plasma level compared to the PRN dosing. As I was mentioning earlier, one of the problems is in pain management, we have mistaken beliefs. We tend to think that we can assess the patient by looking at the patient, and that's certainly not a proper way to assess pain. We tend to restrict the dosage and prolong the intervals due to fear of dependence. Unfortunately, a lot of people who are practicing pain, or not pain, I'm sorry, a lot of people in the medical field, they tend to jump to conclusions. And we think when we see a sickler coming to the ER seeking help regarding pain, everybody volunteers a diagnosis of addiction. And unfortunately, we all volunteer that diagnosis when in fact only a certified psychiatrist can make that decision. I know I am a pain physician, I know how to treat pain, but I do not know how to treat addiction. Even if I do, I'm not licensed or trained to train addiction. So, and unfortunately, we tend to mix medical conditions. We tend to mix physical dependence with tolerance, with addiction and pseudo-addiction. Physical dependence, when you keep somebody on opioids for more than 2 weeks, and then you suddenly stop it, they will get withdrawal symptoms like headache, nausea, vomiting, dizziness, sweating, abdominal pain, diarrhea. These are signs and symptoms of physical dependence, not addiction. Physical dependence is not unique to opioids. It is shared by other medications. Tolerance, when you keep a patient on opioid more than 2 weeks, and then you're going to notice that the patient will require higher and higher doses with times. And this is a shared feature with opioids, benzodiazepines, baclofen, amongst other drugs. So this is just an example. So we cannot call this addiction. Addiction is when somebody uses a medication and they don't need it. They have no actual need for the medication, but they use it to get high, to get happy, or whatever feeling they feel. That is addiction. They use it despite self-harm. Pseudo-addiction, when somebody uses the medication, they have a reason for pain, but they're afraid they might get deprived of medication, so they use more medication than they should, and they can harm themselves. Fear of complications. Well, we are all doctors are supposed to know the medication that they use. They're supposed to know what side effects that they might get, and they're supposed to know how to treat those side effects if needed. So fear of complications, unfortunately, leads to depriving elderly and debilitated patients from treatment. Lack of knowledge about opioids. A lot of people are just familiar with one or two opioids, so they tend to use them most commonly. People are very familiar with pethidine, so they use only pethidine. Very few people now use tramadol. And here, this is the role of presentations such like this to give you an idea about different opioids. Another mistaken belief is that we tend to think that children have less pain. And that is totally not true. Children feel pain as much as adults do. They might be more sensitive to medication compared to adults. For example, paracetamol is only good for mild pain in adults. In children, it might be good for mild to moderate pain. That's the difference. So children are more sensitive to medication compared to adults. It is not that they feel less pain. So this is just a meta-analysis of a group of studies that were done on the rate of addiction in opioid users. And almost all of this studies concluded that the risk of addiction is only about 1 in 1,000. So it is really not fair to deprive 999 patients from treatment just because 1 in 1,000 can get addicted. In one study, if you notice here on the screen, that in one study on sicklers, the risk of addiction here is about 5 in 1,000. And here they included addiction and pseudo-addiction definition together. So the risk of addiction is very low. I'm talking about the risk of addiction to opioids. Addiction in the general population is common, and the most common drug people get addicted to is, of course, caffeine. Caffeine and, of course, smoking is the second most addicting drug. But we're not talking about that. We're talking about opioids addiction, and the rate of addiction is about 1 in 1,000. Now, we have to mention a bit of the pathway to understand pain and how to treat pain and why do we do or give what we need to. A quick revision about the pain pathophysiology. When tissue injury happens, that will lead to release of mediators, like inflammatory mediators, such as histamine, bradykinin, serotonin, prostaglandin, substance P, and others. Prostaglandin is synthesized from arachidonic acid by the function of the cyclooxygenase enzyme. And Dr. Osama will talk about COX-1 and COX-2 inhibitors when we talk about them. But cyclooxygenase converts arachidonic acid to prostaglandins. Prostaglandins will bind to cell membranes, mostly nerve cell membranes, leading to a sensitization of those cell membranes. And that would lead to faster propagation of impulses through the nerves. So prostaglandin is one of the inflammatory mediators that can contribute to the sensation of pain and the worst sensation of pain. Those impulses are transmitted through the A delta and C fibers to the spinal cord. The A delta are small fibers and small myelinated fibers, and the C fibers are unmyelinated. So the impulses travel very fast through those two types of nerve fibers to the spinal cord, and then in the spinal cord, the impulses synapse, and then they get transmitted through the spinothalamic tract and reticular formation to the thalamus, and then to the somatosensory cortex. The main idea of pain management is preventing the impulse from reaching the brain. If the impulse is not going to reach the sensory cortex, the patient will not feel pain. Therefore, you can tackle that. Along the pathway, and hence the concept of multimodal analgesia. And Dr. Osama will talk briefly about that, and I'll show you a slide in a minute regarding the concept of multimodal analgesia. So just a quick review about what we just talked about the pain pathway. Tissue injury can lead to release of inflammatory mediators such as bradykinin and prostaglandin and substance P, and that can lead to all signs and symptoms of edema and hyperalgesia that is associated with pain. Now, repeated impulses arriving to the spinal cord can lead to release of the excitatory neurotransmitters such as aspartate and glutamate, and that can lead to what's we call a wind-up phenomenon or hyperalgesia. Repeated impulses arriving to the spinal cord can lead to spontaneous generation of impulses in the spinal cord, and that can lead to regional sympathetic hyperactivity. What does that mean? That means if you have an incision or a wound, the pain is not only limited to the incision, but actually the pain is present above and below the incision. So it's a wider area. And the explanation is that is the regional sympathetic hyperactivity due to spontaneous generation of impulses in the spinal cord. Another problem with pain is sympathoadrenal activation. When you have pain, that would lead to release of epinephrine and norepinephrine, and that can lead to hypertension and tachycardia, and that can lead to altered perfusion. And here, you can end up with the sympathetic hyperactivity, fight or flight situation, and can certainly divert blood from an incision to the major organs, and that can certainly lead to impaired wound healing. Neuroendocrine response is also one of the problems. That can lead to increase in cortisol and glucagon level, and that can lead to hyperglycemia and negative nitrogen balance, and again, that will affect wound healing. Alteration in the pulmonary function tests. If you have an incision in the upper abdomen or in the chest, that can lead to tachypnea and lower tidal volume, and that can certainly lead to hypoxemia and hypercarbia. DVT is one of the possible complications of pain, because when the patient is in pain, that will lead to decreased ambulation, release of catecholamines, and increased platelet adhesions. All those combined factors can lead to a hypercoagulable status and DVT. Persistent pain is, last but not least, one of the possible problems of pain, of acute pain, is changing into a chronic pain. An example of chronic pain is phantom leg pain or reflex sympathetic dystrophy and other conditions such as that. This is the slide I was talking earlier about regarding the tackling the multimodal analgesia, or tackling pain on all different aspects. And one of the things here I want to draw your attention to, that you can use one drug to tackle multiple areas in the pain pathway. An example of that would be COX-2 inhibitors, for example. It works in the periphery to decrease the inflammatory response, and it also works centrally. So, here the idea is we are trying to use more than one medication or technique to avoid those painful impulses from arriving to the cerebral cortex. In anesthesia, we use things like nerve blocks or epidurals, or even simply local infiltration at the wound prior to the incision. That can certainly help a lot in reducing pain and help reducing the amount of opioids that the patient might need post-operatively. Now, when we talk about pain, first we have, and how to treat the pain, we have to differentiate between the different types of pain, because of course sometimes we need to use specific medications depending on the type of pain. The most common pain that we talk about is post-operatively is the somatic pain. And here there's a skin breakage or a muscle sprain, or it's mostly a connective tissue source of pain. Example would be sprains, arthritis, surgical incisions. And the usual description for that pain is localized, sharp in nature, worse with movement and touch. So to treat that type of pain, most pain medications will help, especially non-steroidals. If the pain is severe, opioids can be very helpful here. One of the other types of pain is visceral pain, and that is originating from internal organs. An example of that would be like a tumor growing or gastritis, chest pain, all those due to cardiac origin. Those are that is a visceral pain. So the description of that pain is usually vague, not localized pain with referral to another part of the body, such as angina referred to the left arm, for example. Usually the pain is constant, dull, less affected by movement. So that's type of visceral pain can be treated or needs to be treated with a stronger medication. Sometimes we need to use opioids and other things. But visceral pain needs a lot of times need stronger medications. But of course, when you talk about gastritis, of course, we use proton pump inhibitors or something like that. But when we talk about other visceral pain, we talk about like angina, for example, you need to give stronger medication. Somatic pain, we've been through that. Visceral pain, and then bone pain, fractures. That pain usually originates from the sensitive nerve fibers at the outer surface of the bone. For example, fracture or even cancer spreading to the bones or severe osteoporosis. The pain tends to be constant and worse with movement. Here, usually we start with non-steroidals, but quite often we might have to go to stronger medications such as opioid. Neuropathic pain, the source of pain here is nerves mostly, not bone, not muscle, not skin. It's only or mostly nerves. An example would be diabetic neuropathy, phantom leg pain, post-herpetic neuralgia, all those different types of pains. The description usually burning, pins and needles, electrical, shooting, those are usually the descriptions of a neuropathic pain. And here, quite often, we need to use other medications like membrane stabilizers, like antiepileptics, for example, like pregabalin or gabapentin. Tricyclic antidepressants can be useful also. And some opioids can also be very useful in neuropathic pain, such as tramadol. Those medications or oxycodone, usually those can be used in neuropathic pain. Pain management sometimes can be frustrating, and some pain patients can be very demanding. And, you know, we are human beings and we sometimes get frustrated, but remember, we work in human beings hospital, not in the hospital on the screen. So remember that you're dealing with humans, you have to have compassion to your patients. So, and what is my point here? Pain management is pretty obvious. You have to know that you need to treat pain. You don't need to see it on a headline. I thought this was a very funny headline I saw in a newspaper. That sadness is the #1 reason men and women cry. And I thought that was very funny. We all knew that. You don't need to see it in a paper to know it. Same way with pain management. You need to treat pain because it's ethical, it's humanitarian, decrease pain-related anxiety and insomnia, decrease pain-related stress hormones, and catecholamine release. How about drugs? I don't have a long time to discuss a lot of drugs, but I'll talk only about opioids. Opioids can be divided either weak or strong. Codeine is considered weak. Everything else is considered strong. Agonists, partial agonists like buprenorphine, agonist antagonists like nalbuphine, and antagonists like Narcan. That's how you can divide opioids. You can divide opioids also as naturally occurring like morphine or codeine, semi-synthetic like heroin and oxycodone, or synthetic like fentanyl and pethidine. Endogenous versus exogenous. Endorphins are opioids. Your body produces endorphins, and those are also opioids. Everything else is exogenous opioid. So you can divide opioids in many ways. How do they work? The opioid receptors is a 7 moiety receptors. It's present in the spinal cord and the higher centers. It is mostly present in the presynaptic and postsynaptic membranes. It's mostly present in these areas: substantia gelatinosa, preaqueductal gray matter, hypothalamus, thalamus, and cerebral cortex. Those are the areas where these receptors are present. When an impulse arrives to the presynaptic membrane, that would lead to calcium influx. So calcium will go in, and glutamate and other excitatory neurotransmitters get released into the synaptic cleft. And then glutamate will bind to postsynaptic receptors, and the impulse gets propagated. If you give opioids, opioids will bind to the opioid receptors, and that will lead to a reduction in calcium influx and a reduction of glutamate release, and that will lead to inhibition of transmission of painful impulses. If you understand this point, you're going to understand how most of the pain medications work, or a lot of pain medications work. You can antagonize the glutamate or any excitatory neurotransmitter by decreasing its synthesis or release, by increasing its uptake or metabolism, or competing with the receptor, with the drug and its target receptor. So here, for example, GABA, Lyrica or pregabalin works on the calcium receptors or the calcium channels. It is not a calcium channel blocker, but it binds to the calcium channels and keep them open. And here it prevents the transmission, the action potential from being transmitted, and that how the pain gets reduced by using pregabalin. So the understanding the concept of this release of glutamate and calcium influx can really help you understand how most of the pain medications work. There are five different types of receptors for opioids: mu1, mu2, kappa, delta, and sigma. I'm not going to talk about all of them. Mostly mu receptors are responsible for the analgesia. The others are responsible for the side effects of opioids. Now we'll talk about individual opioids. The most common and the drug that most people, that we measure all other opioids to, is morphine. Morphine is the standard opioid that we measure all other opioids to. It is a naturally occurring drug. It was first isolated in 1806, so it's been around more than 200 years. It was isolated by a chemist by the name of Sir Turner, and he named it morphine after Morpheus. Morpheus, from the Greek mythology, is the god of dreams. So Sir Turner realized that morphine can cause nice dreams, and he named it morphine after Morpheus. As I said, it is the standard opioid that we measure all other opioids to. It's available oral. You can give it IV, sub-Q. It's available also rectally. You can give it through the endotracheal tube if you have to, but there is no morphine patch, because morphine is a hydrophilic drug, and therefore you cannot have it as a patch. You have to have a lipophilic medication in order to make a patch out of it. Otherwise, you can give it by any other route possible. Few things that to mention about morphine. Morphine has an active byproduct by the name of morphine 6-gluconate, which accumulates in renal failure. Therefore, you have to be very careful about using morphine in patients with renal failure, because patient might have side effects, significant side effects due to accumulation of morphine, especially if the patient getting frequent doses. Also, morphine causes the release of histamine, and that can trigger an attack of asthma in asthmatic patients. So you have to be very careful about using morphine in asthma. So renal failure and asthma, you have to be very careful. Pheochromocytoma is a disease where there's a release of catecholamines by the adrenal tumor. And if you happen to give morphine in a patient where the patient is having a drop in the blood pressure, patient with pheochromocytoma having a drop in the blood pressure, and then you, on top of that, you give morphine and the patient ends up with histamine release, that can lead further drop in the blood pressure. So you have to be very careful about using morphine in patients with pheochromocytoma preoperatively. Meperidine or Demerol or Pethidine, or whatever name you use for it, it's the beloved drug for many, many physicians. And I'm sorry to say I have nothing good to say about Pethidine. I don't like it, I don't use it, and I think it's a dangerous drug. Why? because number one, it's a weaker opioid compared to morphine. It has an active byproduct because it decreases seizure threshold and it can cause CNS toxicity. Again, just like morphine 6-gluconate, normeperidine can accumulate in renal failure. It can cause histamine release also. So you have to be very careful about using pethidine in renal failure and asthma. It can cause corneal anesthesia, even if you give it IV. So if you give a patient a push of pethidine IV, that can blunt the corneal reflexes, so the patient cannot protect his own eyes because his cornea is anesthetized. Combination with monoamine oxidase inhibitors, MAO inhibitors or monoamine oxidase inhibitors are type of antidepressants. Some psychiatrists still use them. Combination of pethidine with MAO inhibitors can be very detrimental. It can cause respiratory arrest, hypertension, and hyperpyrexia. It can cause coma. It can even cause death. So that's why whenever we see a patient, we have to ask about the current medication that they use. But using pethidine in patients who are taking MAO inhibitors can be very serious. Codeine, again, is one of the beloved drugs by most residents or most physicians currently. Codeine is a weak opioid compared to morphine. It actually has to be transformed or metabolized into morphine in the body in order to work. Unfortunately, 10% of the population are lacking the enzyme that metabolizes codeine into morphine. So if you give 10% of the patient for the population can be resistant to Tylenol number 3 and Tylenol number 4. Codeine is available in combination. It's actually available in our country over the counter. Solpadeine, you see the picture. A lot of people, possibly from the audience today, using Solpadeine, and unfortunately, they don't look into the box and they don't know or they don't realize or they don't remember that this product contains codeine. Solpadeine contains 8 milligrams of codeine plus 325 of acetaminophen and 60 of caffeine. It is marketed as an anti-migraine medication because of the caffeine content. Other products codeine compounds is Tylenol number 2, Tylenol number 3, and Tylenol number 4. Tylenol number 3 is the most commonly used. It contains codeine 30 milligrams with 325 milligrams of acetaminophen. Tylenol number 4, the company who manufactured it stopped it because there is a red flag against using Tylenol number 4 in breastfeeding or lactating mothers because of several incidences of fetal deaths. The mother takes Tylenol number 4, it's transformed into morphine in her body, then comes out through the breast milk to the baby, and the baby ends up with respiratory depression, and few babies died because of that. And that's why there is a red flag about using Tylenol number 3 and Tylenol number 4 in lactating mothers. So you have to be very careful when you do that. Codeine is less addictive than the other opioids. I remember being, when I was a child, I think 8 or 9, a lot of the cough syrup preparations used to contain codeine because of its anti-cough suppression properties. But it has less cough suppression properties than morphine. But currently, of course, none of the cough syrups contain codeine, but 30 or 40 years ago, they used to. Tramadol, a lot of you are familiar with tramadol. It's a codeine analog, it's a mu agonist, but it also works on the serotonin and norepinephrine reuptake. So it is very good. It works on pain from different aspects, not only the mu receptors, but from other aspects also. It is a weaker analgesic. It's comparable to pethidine in strength. The dose, in fact, is the same. If you give 75 milligrams of pethidine, then you need to give 75 milligrams of tramadol. It's the same strength as pethidine. It does have a weak byproduct, nortramadol, that can also lower seizure threshold, but not as much as normeperidine does. Chronic use of tramadol can cause hyponatremia. You can give tramadol either as intravenously or orally, and there's actually rectal suppositories also of tramadol. Tramadol available as a plain drug or in combination with acetaminophen, 325 milligrams with 37.5 milligrams of tramadol. The maximum daily dose of tramadol is 400 milligrams, and the maximum dose intravenously is 600 milligrams per day. Oxycodone is a very potent drug. It is the #1 abused drug in North America because it's available as a immediate release and sustained release. A lot of you are familiar with OxyContin. OxyContin is the #1 abused drug in North America. OxyContin comes in strengths as 10, 20, 40, and 80. So remember, when you crush an 80 milligrams of OxyContin, you end up with an immediate release formulation, and 80 milligrams of OxyContin equals to 100 milligrams of morphine. And that's a serious dose, so that's a lot of people can die by abusing that medication. It's available in combination in North America with aspirin, acetaminophen, and ibuprofen. In our country, in Saudi Arabia, it's only available in combination with acetaminophen. 5 milligram of oxycodone with 325 milligrams of acetaminophen. Sustained release in our country available in 5 and 10 milligram only. No higher dose available in our country. Fentanyl, I thought about including fentanyl here. Fentanyl can be given either intravenously or IM or subcutaneously, and that's usually done by the anesthetist. But fentanyl patch, a lot of you are familiar with fentanyl patch. Fentanyl patch, it is not good for acute pain. It's good for chronic pain. Fentanyl is the clean drug. It has no active metabolite. So it can be used in renal failure and liver failure, no problem, because no accumulation. The thing about fentanyl patch is that it needs about 12 to 24 hours to work. So if you're treating acute pain, fentanyl patch will not be a useful thing to use. And the patch is designed to last 3 days. It comes in 4 different strengths: 12, 25, 50, 75, and 100. Even after you remove the patch, when you apply the patch, there will be a formation of a subcutaneous deposit. And then it takes 12 to 24 hours to form enough subcutaneous deposit for it to be systemically effective. And even after you remove the patch, that subcutaneous deposit is still there. So it can last about up to 2 days, sometimes even 3 days after removal of the patch. So if you get a patient with an overdose of fentanyl patch, it is not enough to give a single dose of naloxone and send the patient home, because the patient would have enough subcutaneous deposit of fentanyl in the patient's system. So you have to admit the patient if the patient is getting an overdose of fentanyl patch. This is just a table that shows the equianalgesic dosing to give you an idea of how potent the medications are. And again, I have to repeat that we are measuring morphine, comparing morphine to the other drugs. 10 milligrams of morphine equals IV morphine equals to 30 milligrams oral. So the bioavailability of morphine is only 1/3 when you give it orally. Same thing for pethidine. 300 milligrams of oral pethidine equals to 100 milligrams of intravenous pethidine. And 10 milligrams of morphine equals to 100 milligrams of pethidine. So pethidine is 10 times weaker than morphine. Same way is tramadol, 10 times weaker than morphine. Fentanyl dosing is 0.1 milligram equals to 10 milligram of morphine. So fentanyl is 100 times stronger than morphine. The last point I wanted to make here, look at the codeine. The codeine, 200 milligrams oral codeine equals to 10 milligram of morphine. So 7 tablets of Tylenol #3, 7 tablets per day equals only 10 milligram of morphine, just to give you an idea about the equianalgesic dosing. Side effects of opioids, the most common side effects is actually itching, and mostly with morphine and pethidine because of the histamine release, and the treatment here is antihistamines like diphenhydramine. And fentanyl actually causes itching, but it does not cause histamine release. The mechanism here is central action, and the treatment here is different. If you have itching due to fentanyl, the treatment here would be 5-HT blockers such as Zofran, ondansetron, or granizotron would be helpful in treating itching due to central actions such as itching due to fentanyl. Nausea and vomiting is also common with the opioids. Treatment here is either the weaker antiemetics like metoclopramide. It can help, it may help, but the most potent ones are 5-HT blockers like ondansetron and Ketorol. Respiratory suppression and sedation are also one of the potential side effects. And the treatment here is usually naloxone or Narcan, and we usually give 1 to 3 microgram per kilo as a bolus to treat the Narcan immediately. And then if the patient is, for example, admitted with a fentanyl patch overdose, then you need to start a drip of Narcan, again, about 1 to 3 microgram per kilo per hour. Constipation is one of the common features or one of the potential side effects of opioids. And here, of course, you have to give the patient enough fluid intake, and walking can help. Colace as a stool softener or bowel stimulants like Senokot can also help. Other potential side effects, meiosis, smooth muscle tone, increase in the smooth muscle tone, especially with patients, for example, if you have a patient who has jaundice due to a problem with the ampulla of Vater, they present with abdominal pain and jaundice, and the treatment here is not to give opioids again, but you can give medication like nonsteroidals or even Buscopan can also help with this type of pain here, the smooth muscle tone. Bradycardia to vagal stimulation, histamine release, we talked about that. Central itching, we talked about that of fentanyl. Cough suppression, we spoke about that by action on the medulla. Euphoria and dysphoria, and that's mostly with pethidine because of the effect of pethidine on the kappa opioid receptors, and that can lead to euphoria. So patients feel happy when they get pethidine. That's why it is very highly effective. That's why I mentioned unfortunately, I have nothing good to say about pethidine. I know some of you will be very upset with me because I'm saying this, but I'll have to share with you what I know. These are actually King Faisal data about using morphine and fentanyl PCAs and the side effects that can get with us with that. So 93% have no side effects, and about 5% get nausea and vomiting, and about 2% get itching. So the two most common side effects due to opioids are nausea and vomiting and itching. With that, thank you very much, and I am done.
Thank you, Dr. Adil, for this informative lecture. We're going to keep the question to the end, and now we're going to proceed with Dr. Osama Al-Ahda. Dr. Osama Al-Ahda is consultant anesthesiologist and pain specialist. He's the chairman of the Department of Pain Medicine in International Medical Center in Jeddah, and he's a Canadian graduate, trained and graduated from Canada. Dr. Osama, please.
Thank you very much, Dr. Abdullah, and thank you very much, Dr. Fakhr, for inviting me on this webinar. Can you hear me well?
Yes, sound is okay.
Good.
Yes, your voice is okay.
Great. So I'm gonna go through my slides a little bit more quicker for the sake of time. Okay. So I'm going to just highlight a few points in relation to non-steroidal anti-inflammatory agent and pain management. And I'm going to go through some introduction and what is the insights in relation to the pain pathway, non-steroidal anti-inflammatory side effects, and what are the new insights, and then insights and COVID. And I'm going to go through them quickly so that we're not going to take a lot from your time. At a glance, non-steroidal anti-inflammatory medication are very commonly prescribed by a lot of physicians around the globe. It reach up to 10% of all prescribed medication each year around the world. 95% of patients over the age of 65 are prescribed with NSAIDs at least once in their lifetime. Up to 60% of patients with osteoarthritis in the United States are prescribed NSAIDs. And of course, of those, 27% of patients uses NSAID as an over-counter drug. So they just go to the store and pick up some of the NSAIDs. WHO estimated the market of NSAIDs to $106 billion. So it's really a huge amount of money there. Looking at some of the usability study, this is a trial done, a review done by of the use of the analgesic and orthopedic outpatient department in a tertiary care center for only from June to November in the same year, and they look at how many prescriptions they've done only in that department, and the answer was basically 300 prescriptions of approximately 800 drugs. 62% of these medications were NSAIDs, and 61% of those were prescribed as monotherapy, and the rest are combination. And they use both the selective and non-selective non-steroidal anti-inflammatory in a ratio of 1.3 to 1 toward the non-selective. They also have some opioids, which is about 15%, and also sometimes they prescribe gastroprotective agents with the non-steroidal anti-inflammatory in up to 22% of the patients. So basically, non-steroidal anti-inflammatory agents are commonly used medication all over the world. It's an OTC classified. Almost every household drug cabinet, they contain at least one of them, and therefore they deserve attention from us as a medical professionals, and we should really increase our knowledge about them and what are their interactions with commonly encountered diseases in our clinics and medical therapies. When we look at some of the basic science about non-steroidal inflammatory agents, we have to look at the action of them. We will start with the cell membrane or the phospholipid membrane. Whenever there is any injury, there is a libration of the phospholipids in the tissue. And this phospholipids will be acted upon by an enzyme called phospholipase A. And this phospholipase A will liberate some of the arachidonic acid from the phospholipids membranes. This arachidonic acid is a substrate for two enzymes. The first one is the cyclooxygenase enzymes, and the second one is lipooxygenase enzymes. So the lipooxygenase enzyme actually at the end will produce what we call the leukotrienes, and there are various types of the leukotrienes. It's not we cannot mention them at this time, but they are actually involved in the allergy, inflammation, and it may cause some gastric damage too. But mainly it's involved in immune and allergy mechanisms of our pathologies. While the cyclooxygenase is actually the enzyme that convert this arachidonic acid into the prostaglandins that we know, including the thromboxane and prostacyclins. And these are the one that actually promote the inflammation, produces pain, and increase pain transmission. And of course, also it can cause some gastroprotective layers as well. So by blocking, non-steroidal anti-inflammatory actually blocks the cyclooxygenase, and hence it blocks the effects of these prostaglandins into the tissues. Therefore, these cyclooxygenase comes in forms. It is very complex enzyme, and it is very complex to isolate them in the tissues. But we have a few COX, or we call it cyclooxygenases, referred to as COX. So we have COX-1, which is, we call it as a constitutive isoform of the cyclooxygenase. And it is expressed in most of the tissue under a basal condition, whether the patient has an inflammatory damage or no. While cyclooxygenase 2, or COX-2, is referred to as an inducible isoform of cyclooxygenases, and it is induced whenever there is a tissue damage. And these cyclooxygenase 2 commonly can be upregulated or downregulated in the tissue based on the pathology that is needed for it. Cyclooxygenase 1 are found in the blood vessels, interstitial tissue, smooth muscles, and platelet, and even mesothelial cells, while COX-2 mainly predominantly found in the parenchymal cells and, of course, many other tissue. Of note, we have something called cyclooxygenase 3, which is a variant of cyclooxygenase 1, and that is mainly present in the brain tissue. And this is one of the enzymes that is believed to be blocked by the commonly used drug called paracetamol or acetaminophen. And therefore, the paracetamol or acetaminophen are proposed to work in the brain tissue rather than the periphery. When we go to tissue perspective with regard to the non-steroid anti-inflammatory, we divide them mainly into the three groups, which is the GI, the kidney, and the cardiovascular system. In the GI, prostaglandin E2 is what we call the gastroprotective prostaglandin that actually increases the mucus secretion and increases the bicarbonate and causes what we call mucobicarbonate secretion that is under the epithelial tissue, which usually can protect the stomach from the acidic nature of the cavity of the stomach, and therefore preventing the gastritis and the peptic ulcer disease. And hence, if we block by non-steroidal anti-inflammatory this enzyme, then we have a higher risk of gastritis or GI bleeding. When we go to the kidney, the prostaglandin E2, but in more prostaglandin I2, in fact, increases or what can cause vasodilatation and increases the GFR at the kidney glomerular level. Also, it increases sodium and water excretion. And hence, if we block this prostaglandin by the non-steroidal anti-inflammatory, then we will have a sodium and water retention. There is a potential for hypertension, and the patient may go into acute kidney injury if persistently used. With regard to the cardiovascular system, we have mainly the thromboxane that is working in addition to the prostaglandin I2, but we have the two different oxygenases, cyclooxygenase 1 and cyclooxygenase 2. Cyclooxygenase 2 usually work on prostaglandin I2, while the cyclooxygenase 1 work on thromboxane A2. So basically, thromboxane can cause vasoconstriction, while prostaglandin I2 can cause vasodilatation and inhibition of platelet aggregation in the cardiovascular and the vasculature of the heart and the brain and other tissues. And therefore, if we have a block of the vasodilating action of the prostaglandin I2, then the vasoconstricting effect of the thromboxane will be predominant, and then the patient may develop either stroke or cardiovascular compromise and or myocardial infarction. And hence, there is the risk of having an increased risk of cardiovascular complication from non-steroidal anti-inflammatory in susceptible patients. As Dr. Adil said, during the pain transmission from the periphery toward the brain, the non-steroidal anti-inflammatory mainly works on the peripheral part where the initiation of the stimulus is there by reducing the amount of the prostaglandin there, as well as there is some work on the spinal cord level, and also there's some work on the brain as well, mainly through the inhibition of COX-3 by acetaminophen. But most of other non-steroidal anti-inflammatory work generally on the peripheral side. These are the commonly used non-steroidal anti-inflammatory in our country, and I'm going to skip that for the sake of time. This graph showing the different efficacy of different non-steroidal anti-inflammatory we have, and to compare them, we have to use a concept called NNT, or number needed to treat, which is basically the number of the patient needed to be treated with this drug to have at least one of them 50% of their pain improved. And if we look here at just the paracetamol or acetaminophen, we could see that the NNT is somewhere between 4 and 5, while if we use diclofenac of 25 milligram, the NNT is around 2.5 to 3. But if we have a combination medication, we combine the acetaminophen and ibuprofen, let's say ibuprofen 400 or ibuprofen 200, you will have an NNT of less than 2. So basically, if you treat 2 patients, at least one of them will be 50% improved, which indicate that combination therapy works much, much better than doing a single therapy. But of course, combining the medication for pain medication has to be different classes, not the same class. So you cannot get 2 non-steroidal anti-inflammatory together like diclofenac and naproxen together. We could not do that. So generally, side effects of the non-steroidal anti-inflammatory is huge, and it's one of those which prevent us from using non-steroidal for a long time. Gastrointestinal side effects, renal damage, cardiovascular risks, and it is, of course, it's contraindicated in cabbage patient. And of course, there is allergy and anaphylactic reaction, which is very rare. Cardiovascular risks has been attached to non-steroidal anti-inflammatory recently, and specifically for those new groups, which is COX-2 inhibitors. And there was a black box warning, and then the removal of all COX-2 from the market. And then after, really, they reviewed the data, and then the meta-analysis reintroduced again. This data here, just to tell you that there is this review article or meta-analysis shows that there is really no difference between the selective COX-2 or the mixed COX-1, COX-2 inhibitor. So basically, there is no major difference between, let's say, naproxen and celecoxib or celecoxib and diclofenac. The only one that has shown a statistically significant difference is rofecoxib, which is completely taken off the market. Yet the celecoxib still used, and it is safe, and its incidence or the risk of having the cardiovascular risk from celecoxib, which is COX-2 inhibitor, is probably similar or even better than the risk from other non-selective non-steroidal anti-inflammatory agents. And basically, they conclude that cardiovascular adverse effect may not be based only on COX-2 selective agent. Rofecoxib was the most important one, and it's taken off. Other COXIB demonstrate no difference compared to the placebo or other non-steroidal anti-inflammatory, and celecoxib shows, in fact, a lower incidence and of the risk of the cardiovascular complication. compared to other non-steroidal anti-inflammatory. Looking at the bone healing, which is also a common debate between anesthesiologists and pain physicians and the orthopedic surgeons or colleagues. They really, if there is any patient with a bone fracture, they really don't prescribe non-steroidal anti-inflammatory in a fear that these agents might reduce bone healing and hence increase the incidence of non-union. And we will look at this issue because to have a union in the bone, you have to have a formation of callus, of course, non-steroidal anti-inflammatory is not only a pain reliever, but also it decreases the swelling around the tissue around the fracture site. But if we take their concern into consideration, at least scientifically, if there is a bone fracture, there is a formation of callus where the end of these two fracture site bone are not very close or not reduced well. And that callus will be healed by a process called endochondral ossification. So the callus formation first happened, and then the ossification happens afterwards. While if we do any surgery to these fractures, and then we stabilize the fracture, we remove the hematoma, we put some fixation or rods inside, and the end of the bone are actually aligned and attached together. In that situation, the bone healing occurs by what we call primary bone healing. And non-steroidal anti-inflammatory does not affect primary bone healing at all. It may affect endochondral ossification. And therefore, if the patient with fracture are exposed to surgery, we can give the non-steroidal anti-inflammatory with no fear at all of non-union. While if the patient has fracture where the fracture site is not reduced, we have to be a bit careful on that. So non-steroidal anti-inflammatory has been shown to prevent heterotropic ossification, yes, specifically COX-2, but the data on a clinical ground did not support that. In vitro study of the animal trial demonstrate an inhibitory action of non-steroidal anti-inflammatory on osteogenesis of the bone, and that is theoretically may cause bone healing deficiency, but again, clinically it was not proven. And therefore, these clinical relevance on post-surgical fracture healing and fusion of the spine is still questionable, but the tendency that the non-steroidal anti-inflammatory can be used in a post-surgical patient or post-bone fracture or post-spine surgery with no fear of healing problems or non-union. This is one of the last meta-analysis here. Shows again, it's a systemic review. They looked at over 300 papers, and again, they concluded that the short duration of non-steroidal anti-inflammatory is safe without significant increased risk of sequelae related to bone healing. But bone healing is not affected only by non-steroidal, but also opioid has been shown in animal trial to reduce bone healing too. And this was done using the rabbit as an animal experiment, and they half of them are exposed to opioid and the other half are not exposed to opioid. And both of them, they did iliac crest grafting. And you could see that those who are on the right-hand side picture here, that those who are exposed to opioid, they show a lower bone volume and lower trabecular number. And there is a lot of separation in the bone, while those who are placebo has a very good bone takeoff. And basically, they conclude that the systemic opioid may also lead to delayed fusion in case of spine surgery. But despite that, we still use opioid, and clinically, we did not see that is a major impact. I'm going to go in these slides about what are the new trend in non-steroid anti-inflammatory. Combination therapy, non-steroid anti-inflammatory with other chronic drug use, such as patients who are hypertensive and has osteoarthritic disease. They have both antihypertensive and treatment for osteoarthritis with a long-term non-steroid anti-inflammatory. So the combination of that will actually enhance the prescription adherence. And the recently FDA-approved drug Consensi is actually a combination of celecoxib, which is a COX-2 inhibitor that can be used for long term, and amlodipine, which is an antihypertensive calcium channel blocker, and they combine it together to be used once daily, and it shows a very good efficacy. Another new insight is the introduction of varicoxib sodium, which is basically the first injectable COX-2 inhibitor. It's an FDA approved and recently Saudi FDA approved for the treatment of acute postoperative pain. The initial dose 40 milligram, and then the maximum dose daily is 80 milligram. And it's been used for treatment of most acute postoperative pain. It is available in my center, and there's some other centers around the kingdom as well. Another new insight about non-steroidal inflammatory is the combination of cyclooxygenase inhibitor and lipooxygenase inhibitor in a mechanism called LOX-COX inhibitor. And basically, we are reducing not only the prostaglandins, but also the leukotrienes. And by doing so, there is a very good evidence in animals, at least, that this can limit the vascular changes and the GI damage and the renal damage from the non-steroidal anti-inflammatory alone. The drug now is in phase 3 clinical trials is licofilone, and it's probably once it's finished the first 3 trials, then they will go into the distribution phase. Another new insight about the non-steroidal anti-inflammatory is the NOSH insight. We call it NOSH insight. NOSH, non-steroidal anti-inflammatory agent, is being shown to be as an anti-cancer, or we call chemoprotective property. But we cannot give it for cancer patients for a long time because of its potential side effect. And therefore, there was a development of a hybrid molecule between a traditional non-steroidal anti-inflammatory and a molecule that can liberate the H2S and nitric oxide, moiety. And by doing so, then this will oppose the side effect of non-steroidal anti-inflammatory. And therefore, we have now development of what we call NOSH aspirin and NOSH naproxen and NOSH diclofenac. And primarily, it's going to be used for cancer therapy, but also can be used as an anti-inflammatory and in pain medicine in the future, because it is lack of side effect and can be used for a prolonged time. The few coming slide about non-steroidal and COVID. We know that prostaglandin has a key role in mediating pain and inflammation, and therefore non-steroidal inflammatory drug can inhibit these prostaglandins. There was a study in 2007 found that the increased risk of severe skin and soft tissue complication in children whom they have varicella infection, and they were on non-steroidal anti-inflammatory. And then hence, there is some combination, they stated that non-steroidal anti-inflammatory might increase the disease of any viral infection, specifically respiratory virus. And that is supported also by some research done in the basic science by a French group looking at the aspirin and naproxen as that can cause increase in the interleukin 6, which can in fact be determinantal in viral infection because it will reduce the immunity and propagate the viral infections. The group from UK and the National Institute for Healthcare Excellence, they actually looked at this issue carefully in the recent days, and they published their conclusion that basically there is no evidence to suggest that non-steroidal anti-inflammatory might worsen any viral infection of upper respiratory tract. In fact, that also supported by a report from the World Health Organization, which they formulate a group. They looked at this issue of non-steroidal anti-inflammatory that might affect the COVID-19 or any other viral infection. And they started their work in March, and they published it on 19th of April. And it was a good systematic review. They looked at all the non-steroidal anti-inflammatory in relation to respiratory infections, all kind, at all ages. And again, they come up with a total of 73 studies. Although there was some limitation in their work and it was very quick, yet their conclusion is that at the present time, there is no evidence that any severe adverse effect occurs in relation to COVID and the use of non-steroidal anti-inflammatory. And with that, I'm going to summarize my presentation. Non-steroidal anti-inflammatory is commonly prescribed anti-inflammatory agent for pain management. The cardiovascular risks are not only related to COX-2 inhibitor, but also can be related to the mixed COX-1 and COX-2. Although naproxen is probably the best agent used with the lowest risk for cardiovascular complications. Effect of non-steroidal in bone healing is still questionable, but can be used safely in post-operative period. New insights will open the horizon for the future anti-inflammatory agent that has a very low side effect and can be used more frequently. And there is no data to suggest that non-steroidal anti-inflammatory will increase risk of COVID patients. And all physicians must balance the benefits and risk for all their patients with regard to non-steroidal anti-inflammatory. With that, I will thank you for listening to me, and I will stop here. Thank you.
Thank you very much for our speakers. It's very informative. I actually have a huge amount of questions, and also our attendees today is 2,800, which is a huge number. I understand most of them are really attached to the pathway of the pain itself. And from different aspects, one of the major questions they always in the rounds ask us about vascular pain in combination with pathophysiology pain. For example, if you have a patient who is cardiac and diabetic at the same time, and there is a pain, let's say back pain, we always face this question: what is the proper analgesic for this type of patients?
Is that for me or for Dr. Sama?
It's for Dr. Kaki, I think.
Dr. Kaki, I think it should be. Should answer that.
Thank you for the question. Now, pain, it's one of the subjective things, and I always say we have to tailor the management to each patient. If there's a neuropathic component, you have to give him something for the neuropathic component, as Dr. Adil covered in his lecture, the tricyclic, calcium channel blocker, or other, but you have to weigh the benefit against the side effect of this medication, especially in a cardiovascular disease patient. You don't want to give something that induces tachycardia for somebody with ischemic heart disease. And at the same time, you give him something for nociceptive pain. So you need to give him a multimodality, not one single drug.
So you have a strong heart.
Sorry?
Prof. Kaki, you have a strong heart to use more than one. In our round, if we say just one painkiller, it's actually a bomb. What about if you have more than one? Great. The other question we always face also in the refractory angina pain. We always have this problem, and lots of our patients are scared of using a kind of strong analgesic, opioids, for example. Sometimes they even advise them to take tramadol, Lyrica, and so on. So what is your recommendations, especially these kind of patients? Some of them are for a maximum medical therapy, where you cannot interfere anymore. So you just need to relieve the pain.
So this is for Dr. Adil then.
Just to go back a little bit, when you face a patient who is very complicated and you're not sure what medications to give, like a patient with low back pain, with cardiac disease and diabetic, and maximize on other medications, quite often we offer the patient procedures, such as epidural steroid injection for somebody with a disc problem. So those complicated patients, you can certainly refer to the pain management. Regarding this, patients with angina, of course, when you explain to the patients that they're maximized medically to treat their angina and there is nothing more and they still complain of pain, then it makes sense that they should start some stronger medications as tramadol or Tylenol number 3 or gabapentin for if the patient has a neuropathic element. But you just have to talk to the patient and explain and reassure. Of course, now there are other techniques or methods to treat angina pain, such as neuromodulation. This therapy is not available in every center. It's available in the major centers in the country, like King Faisal Specialist Hospital, Jeddah and Riyadh, and King Saud University. In Jeddah also is available in the National Guard. So in some hospitals, this therapy is available for patients with refractory angina who are maximized medically, and the patient can still have pain, and they are using oral medications such as opioid, and they're still not happy and not comfortable.
Thank you, Dr. Adil. We're going to proceed with the questions. Okay. There was a lot of questions regarding the certificate. I repeat myself, you're going to receive it by email, so don't worry about it, okay? And it will be registered. It will take a few days. There were another questions actually related to back pain, so we're going to leave this for the webinar related to back pain as well as cancer pain that will be covered in the other webinar. This question, I think, to Dr. Adil, what is the best opioid and tricyclic antidepressant with less side effect currently in use?
Every single medication in clinical use has some side effects. You just have to weigh risk and benefit. There is no single medication which has no side effects. If you take an overdose of acetaminophen, which is available now in the gas station, you can end up with liver failure. So you have to weigh risk and benefit. So there is no ideal medication. You just have to start with a small dose and go higher. Usually we start with weak opioids such as Tylenol number 3 or tramadol as on PRN basis, and then if there is another element other than somatic pain, for example, neuropathic, we add stuff like medication like membrane stabilizers such as gabapentin or things like that. So there is no clear-cut answer for this question. It depends on the patients, and we just deal with each case individually depending on the situation.
Okay.
Doctor, regarding the non-steroidal, the IV non-steroidal, they're asking me, are we able to give it to cardiac patients for acute pain or chronic pain? Not the cabbage patient, of course, they are contraindicated. But what about if I have a chronic pain with the cardiac patients? Can we use the IV non-steroidals or not?
Okay, so the IV COX-2 inhibitor recently introduced is basically only for use of for post-operative patient only for first 3 days, and this is where it is approved. But there are other IV agents such as Z4, we call lornoxicam, and sometimes there is also intramuscular or parenteral, not parenteral, intramuscular injections such as diclofenac. So if the patient in our clinical judgment, if the cardiac patient on anticoagulants, then use of non-steroidal anti-inflammatory is considered to be safe if the pain necessitates the use of non-steroidal anti-inflammatory. Of course, it's better to avoid them if you can, but if you really, really need them and the patient's anticoagulate, then you can use them. But with regard to COX-2, is only used for acute post-operative pain, not chronic pain patients.
Prof. Kaki, it's your turn.
Yeah.
Okay. Now this is a question to Dr. Adil. Some people, they're asking if pethidine is a weaker drug, what is the alternative for that, for post-operative pain you're going to use? And another question related to pethidine, it has an anti-shivering effect following general anesthesia. Didn't you think that it's the only remaining indication for the use of meperidine? And could you tell us about the mechanism of action?
Wow. Okay. طيب, what opioids to use alternative to pethidine? You can use the others. If you insist to use the same weak opioid, then tramadol would be the best alternative. You just have to remember the name. The dose would be the same, the frequency would be the same, and the route would be the same. So tramadol is a reasonable alternative without the side effects of pethidine. Morphine, of course, can be used. Multimodal analgesia, starting regular paracetamol and regular non-steroidal unless there is a contraindication. Some membrane stabilizers like gabapentin can be also used to treat acute pain. So it's a multimodal analgesia is the best answer for this. But tramadol and Tylenol number 3 are reasonable alternative. You have to choose opioids. The best tricyclic antidepressants, unfortunately, most of them has side effects such as dryness of the mouth, retention of the urine. Sometimes they have palpitation, and that's usually with amitriptyline, but the nortriptyline would have less side effects. So I would go with nortriptyline as my choice if it's available in your hospital. But I would go, my choice would be actually gabapentin rather than tricyclic antidepressants. That's my personal preference. Regarding shivering with tramadol, with pethidine, yes, pethidine is still being used for post-operative shivering, but I'll have to say that tramadol can also be used for shivering post-operatively. And the mechanism for both action, for both medications, is central action to decrease shivering. So pethidine has no room any longer, even for post-operative shivering, because tramadol can do the same job.
The question to Dr. Al-Ahdal, they're asking you non-steroidal and COX-2, does it increase the thrombosis for patients with ischemic heart disease with a recent PCI or not?
Okay. Of course, everything is judged by risk-benefit ratio. Most patients on who had the PTC or the procedures for the cardiac procedures, they are on anticoagulation. And once they are on anticoagulation, then the risk of having a thrombosis will be will hopefully probably not altered by the use of the non-steroidal anti-inflammatory. Yet again, is if you are not in a situation where you can avoid the non-steroidal, you can avoid them, it's better. If you cannot avoid them, then probably then you can use them as long as the patient is on anticoagulation. That's for the cardiac cases. I just remind you that if you keep the patient in pain, pain itself can actually increase the risk of cardiovascular complications. So basically, if you treat the pain appropriately with the least, maybe a combination therapy, a smaller dose of non-steroidal with a smaller dose of weak opioid, that may be helpful. But again, as long as these patients are on anticoagulation.
Okay, great news that we have 10 minutes extra for this webinar because of the huge amount of questions that we are getting. Professor Kaki, it's your turn now for your question.
Okay, so one more question to Dr. Al-Ahdal. 2 days ago, a British study claimed that the use of ibuprofen is useful in treating symptoms of COVID-19. Is it allowed to be used?
Okay, again, the French report that it might be detrimental to these patients and might worsen COVID patients. Yet, as I said in my slides, that the WHO actually did a very good review, and it found that there is no evidence to suggest that non-steroidal anti-inflammatory will worsen the COVID symptoms. And therefore, to be used as a treatment It's something new. We need to look at it from the data point of view. Most of the data until now, they are about the COVID, is that there is no cure. All the medications are in the trials. If you look at COVID as a disease, it's just a recent disease, and you cannot find a very good randomized clinical trials for the treatment. It's all based on the guidelines and the clinical expert until now. So I cannot tell you that ibuprofen can be used as a treatment for COVID patient at this time. No.
The question to Dr. Al-Ahdal and Dr. Adel is always facing us, which is what is the difference between addiction and tolerance? Which lead me to another question. Are we going to stop tramadol suddenly, Lyrica suddenly, or does it have to be gradual? So who's going to take this great question?
I will answer the question since I mentioned about the addiction and the tolerance. Tolerance is a feature of opioid amongst other medications such as benzodiazepines, baclofen, and other medications. Tolerance is escalation of the dose with time. And this is a feature of many medications. Addiction is actually, an addict is a person who is using a medication that he doesn't need. There is no reason for him to use the medication, and he uses it despite knowing that this will harm him. So like a self-destructive behavior. So that's an addict who uses a medication and he doesn't need it. Pseudo addiction, when he is a patient who has a reason to use medication, opioid, for example, a patient with cancer or a patient with low back pain or whatever pain condition, and the patient is afraid that he might get deprived of medication. So he uses it and he knows that he will be self-harmed, but he continues to use it. So that's pseudo addiction. So that is the difference between tolerance and addiction. Now, should we stop tramadol suddenly, or should we stop Lyrica suddenly? It's honestly depending on the dose. The maximum dose per day is 400 for tramadol, and the maximum dose per day for Lyrica is 600. If a patient is using 75 milligram of Lyrica once daily, then I would say yes, probably you can stop it suddenly. And tramadol, patient if using less than 100 milligrams per day as needed, then possibly yes, you can stop it because the symptoms of withdrawal will be very minimal. But if a patient using 400 milligrams of tramadol per day, you cannot certainly stop 400 just like that, cold turkey. You have to taper it down. And the same for high dose of Lyrica. So you taper it down, or you switch to a drug from the same class. So tolerance, withdrawal symptoms will not appear. I hope that answers it.
Great. Professor Kaki, it's your turn.
Okay, Dr. Lahdal, again, regarding the long use of NSAID for what is the side effect on the kidney, and is there any protective mechanism like the protein pump inhibitor for the GI?
No, the only protecting mechanism is just a frequent check on the renal function and the creatinine level or GFR for the patient on a regular basis. There is nothing to, until now, there is nothing to protect the kidney from the non-steroidal anti-inflammatory. You can use them for a long time as long as you follow up the patient well. Only we are hoping for the new agent, which is the NUSH or the LOX-COX inhibitor, that might give us a very good anti-inflammatory with very limited effect on the kidney. That's in the future. But for now, the only protective is your frequent follow-up on the patient with regard to kidney function.
Prof. Kaki, I think this is a very interesting question, talking about novel gene. I think we all heard about it. And they're telling us it's a good drug, it's a pain relief. Why is it prohibited from Saudi Arabia? It
causes aplastic anemia. So it's still in use in Germany and France. It's one of the wonderful antipyretic drugs and a good painkiller. The problem that it's been withdrawn from the market in Saudi Arabia, it's the chronic use. With chronic use, it causes anaplastic anemia. So that's the reason they withdraw it. But for acute pain, it's one of the wonderful drugs.
Okay, great. And the other question for tramadol, they're asking us, can we use it for sickle cell patient, or it's not recommended?
Yeah. Yes, you can use it for sickle cell anemia. Yeah.
With high doses up to, I think, even 400 milligram per day.
Depending on the patient's use, yes, exactly.
Okay,
I
great.
have some patients on 400 milligrams per day.
Okay. Prof. Kaki, it's your turn.
So what is the preferred opioid or non-opioid regimen for postoperative pain to help reduce hospital stay? Is hydrochloroquine available in Saudi? Yeah, it's available, but I will leave the first part of the question to Dr. Adil and Dr. Sam.
Regional anesthesia, of course, we spoke about multimodal. It's always multimodal is the correct answer. So we try regular paracetamol, regular non-steroidal. If there's no contraindication, a nerve block or a local infiltration or an epidural, those can certainly reduce the amount of opioids that the patient might need postoperatively, allows early ambulation, early return of bowel movement, early oral intake, and therefore faster discharge from the hospital. So multimodal analgesia.
I just want to add that this, I think, depends on the nature of the surgical intervention as well as the patient threshold level. And I mean, this is, you have to follow up the patient and see that some patient comes out of the hernia repair, they don't need even a single dose of opioid. And some they come for 1 week or 2 weeks of everyday opioid. So basically it's up to the nature of the surgery as well as the threshold of the patient's pain.
Agreed, absolutely.
ختامها مسك الدكتور Kaki. Of course, I'm always trying to get the best out of Dr. Kaki. They have a very actually query, a very important query. When you have a post-MI patients, you know, usually it happens in the morning. So patients are scared or afraid of sleeping. So it might have also some kind of pain or insomnia. What's your recommendations for this kind of patients, especially if they are, again, cardiac with old age? So what do you recommend for those kind of patients?
I noticed that the minute you treat their pain, they will be happy and they go to sleep. I know that my colleague in the cardiology department, they like to give them lorazepam, but I don't like benzodiazepine for a reason that the patient gets used to that. Maybe 1 or 2 doses, not that harmful, but relieve their pain, they would be happy. So treat the cause, they will go to sleep.
Did you recommend melatonin for those patients, or do you recommend
yeah, you could use melatonin, but it's not on the formulary of the hospital formulary. I don't know, at least in my center, it's not. So it's not yet used as a scientific drug. It's a complementary one, yeah.
I really want to thank you very much for this great webinar. You can't believe that all the attendees, they did not even leave until now the podium. They are waiting for our questions and answers, which means it's a great success for this webinar. I really want to thank Dr. and Prof. Abdullah Kaki for your great collaboration and help for the Saudi Heart Association and for your association. I want to also thank Dr. Adil for the pathway and all the pain pathways that we had today with the different medications that we really get a lot of information from this very nice slides. Dr. Usama Al-Ahdal, thank you so much also for the informative talk. Even you covered the COVID and the part that is always actually tackling our healthcare professionals and the social media. Should we use these drugs or not? So thank you so much. Thank you for having you all in our very successful webinar. Thank you for our attendees. It's really nice to have you even after 10 minutes of the webinar. Thank you, Pfizer, for sponsoring this webinar. And inshallah, this is only the start. We will keep on with this great collaboration, and we try next time to cover different topics, pain topics, inshallah, with your great experience. Prof. Kaki, the mic is yours if you want to add anything.
Yeah, I'd like to thank the attendee for staying to the last minutes. That's great, and hopefully they will join us in the coming webinar. As I told you before, there will be more. There was a few questions about cancer pain, phantom pain, neuropathic pain, and so on. This will be covered in the coming. I'd like to thank both distinguished speakers, Dr. Adil and Dr. Osama, for their effort and time. And have a good night, and see you, inshallah, in the coming webinar.
Thank you so much.
Thank you very much.
Thank you.
Thank you. See you soon, inshallah. في أمان الله. مع السلامة.